Hello, everyone. Well, I think my invite today do not need introduction. Professor Martin Tobin, thanks a lot for your time and to be with me today.
Thank you for inviting me.
So, what is the main reason for this discussion? And of course, you have written recently an article entitled Defining Arts Again, a Plea for Honesty. So this paper, which was published in the Blue Journal, sparked on me many thoughts about this topic. I have already discussed with many other colleagues, particularly from Latin America, in the region where I work at. And some question for you have arisen after the reading of this piece. So in your paper, you argue that RDS definitions have turned into an obsession among trialists speaking to one another about how best to homogenize the recruitment of patients into clinical trials. And in some way, you also suggest that change in definitions and redefinitions are an irrelevant distraction to the care of patients. So my first question to you, Professor, would be, what do you mean by distraction? Please expand on your thoughts on this matter.
I mean, ARDS is extremely important to critical care medicine, whether it's in adults or pediatrics. It's one of the main diseases that we take care of. And the people who do research on it have written several different definitions from when ARDS was first described more than 50 years ago. But their focus is to recruit patients into randomized controlled trials. That's fine. And that needs to be done. But for those of us who are taking care of patients at the bedside, that is not the focus. It's very different. And all of these definitions are a distraction. Taking care of patients, you have to focus on the patient. Unfortunately, I find house staff, they're focused on the words in the definition. And that leads to bad medicine.
So
it's a big distraction.
It is a big distraction for the most of clinicians who take care and who do not do research, right?
Yeah. I mean, you need to make a distinction that you need to do research and you need all of that stuff. And I've spent my life doing research. But I've also spent my life taking care of patients. These are very different. And when you're taking care of patients, you need to know what you focus on.
And what is our focus?
Your focus is on the patient. The only thing that is important in clinical medicine is the patient. It is not the papers that are out there. You focus on the patient.
But could you please expand a bit more about this? I mean, when you are taking care of a patient with acute respiratory failure, then some fellow or some clinician says, well, this patient has these radiological findings, they have an acute insult, an acute lung injury. So does he or she have an RDS? Yes or no? Should it change my approach to that very single patient?
No, I believe that is the appropriate approach, but it needs to be qualified. So I'm standing at the bedside and the resident is standing at the bedside, and I asked the resident, please tell me what you see here. And so he talks about hypoxemia, and he talks about how long there was, how long the patient was sick before he showed up in the ICU, and different features. And so then you can say, does this patient have ARDS or not? And I would base the diagnosis of ARDS based on what I've seen in the past. That's for me. It's different for a resident. I fully understand that. They can't operate quite the same way. But the problem is that so much time is focused on the PF ratio, on the particular features of the X-ray, the number of days since the insult. So all of these things are the focus. They are important when you do randomized controlled trials. I fully grasp all that, but they are totally irrelevant to forming an opinion, because all you're saying is this a reasonable label to use in this patient that we call him ARDS? And that's fine. But it is, now we're looking at probably the fourth definition of ARDS, because my article is not really a full-blown article. All it is it's this little small letter with 400 words, right? And it's provoked by somebody, by the next article that's going to come out telling us another definition of, we're going to get the fourth definition. Einstein commented many years ago, when you keep doing the same thing over and over and you expect different results, that is called insanity. And that is exactly what is going on here with ARDS.
We're entering in an insane dimension of critical care?
No. We've been there a long time. We're not entering it.
So, Professor, what is RDS for you?
ARDS.
Does it even exist?
I believe it exists, but I mean, it's a syndrome.
Okay.
You have to make it. Some clinical medicine deals with uncertainty. As a doctor, you are operating in a realm of uncertainty. When you do research, you are trying to eliminate as much uncertainty as you can. You try to carefully control your laboratory conditions. So it's a very different modus vivendi. It's a very different modus operandi, doing research than clinical medicine. And so to me, there's certain conditions that are diseases. So it's very easy for me to figure out if somebody has adrenal insufficiency. That is Addisonian disease. It's a particular disease. I know the cause of it. I know the manifestations. I know everything. When you're dealing with syndromes, and a lot of clinical medicine is dealing with syndromes, you don't have causation. But you still have to take care of the patients. It's not the patient's fault that he has a syndrome versus a disease. It doesn't matter. These are, so I mean, to me, ARDS is very simple. It's a syndrome. It was described in 1967 by Ashbaugh and Petty and the other people. And for me as a clinician, the way they described it is perfectly fine. All I do is follow what they said it was, and that's how I operate. I believe the papers since 1967 about trying to define what ARDS have been extremely unhelpful to me as a practicing doctor.
And you wrote in this piece that RDS definition in a way today is a sociological construction.
That's a separate part. Yep. So I mean, yes. So if you have different diseases, and from a scientific point of view, and from a philosophical point of view, and from a particular branch of philosophy called metaphysics, and these matter, because as a researcher, I would much prefer to be dealing with metaphysical entities, because then I can precisely measure them. But I'm a doctor. I have to deal with the more complicated world. But if you take measles, measles is very simple. It is caused by a particular entity, a virus. It produces a particular pathophysiology that is very predictable from one patient to the other. And as soon as you see the rash, any mother can diagnose measles without any medical degree. It is a natural kind. A natural kind is something that exists in nature. So this is going back to the earliest descriptions of diseases. That's what we're looking at. The problem is that ARDS is not that. So the very opposite of a natural kind is a sociological construct. Okay, so the example I give is the city I know very well is Chicago. And if you go into Google Maps, you will see that from 1849 to the present, that the size of the city of Chicago and the definition has changed. And it's based on politicians who are gerrymandering the vote. They change the borders around the city of Chicago so as that they will win the next election. Okay, it's understand they do this in every city around the world. It's not unique to Chicago, but that is a sociological construct. Mm-hmm. It's the exact opposite of measles. The problem is that ARDS is nothing more than a sociological construct. It is you can use different criteria to say, well, unless you meet these borders like Chicago, you don't fit within Chicago. You are outside our voting range and you don't get to vote. It's the same thing with ARDS. So this is a games that researchers play. It's understandable, and that's just the way it is. But it has nothing to do with clinical medicine.
Well, but I wanna argue with you about this. In fact, yourself I have read your papers and books. You always say that the most relevant thing a clinician can do is to make a diagnosis. Mm-hmm. So can RDS be diagnosed?
Oh yeah.
Okay. What is your RDS?
I mean, it's very simple. It's not complicated. It is, the problem is that all of this discussion is making it unnecessarily complicated. ARDS is simple. It's a syndrome. That means it's kind of shabby. It doesn't have a very nice suit compared with other disorders. Okay. And so all it is simply based on, does the patient have hypoxemia? Is the patient having difficulty with breathing? Is the patient having shortness of breath, dyspnea? Okay, and does the patient have infiltrates on the chest X-ray? And do you find a low level of oxygen when you measure oxygen in the patient? And if you find that pattern, it's pattern recognition, you diagnose ARDS. But ARDS also is never a final destination. It's not the place where the train stops. You always have to continue the journey to find out what is the underlying cause.
What was the cause?
And so the treatment of pancreatitis is extremely different than the treatment of pneumococcal pneumonia. And both of these will produce ARDS.
So in your piece, you say, and you state, I mean, what do you mean when you say RDS panels, who are those colleagues, most of them researchers, who sit around a table or Zoom or via Zoom and say, well, we have to change this definition. And you wrote that these panels have operated in a shallow and superficial level. Where is the superficiality or the shallowness on those definitions?
They never tell you that ARDS they don't tell you it's a sociological construct. They don't tell you it's not a natural kind. They don't They never mentioned the word epistemology. They never mentioned the word ontology. These are, so they have that by definition, then they're operating at a very superficial level.
So, Professor, in the 2000, you were responsible of the editorial in the New England Journal of Medicine on the publication of the ARNEST RCT, and you entitled that paper, "The Culmination of an Era in Research on the Acute Respiratory Distress Syndrome." This was 22, almost 23 years ago. What have changed? What was the era which finished in that time, and what came afterwards? Do you think any has changed? Did you predict this new dimension we are in about defining one and again?
I certainly didn't predict. I mean, the thing is, in that editorial, one of the main things I point out, first of all, I say that it was the culmination of research, which was correct. It was 40 years, basically, of research. And the main outcome of that research was that we knew how better to turn the knobs on the ventilator to lower the tidal volume. In reality, that was happening probably for 10 years before the publication of the trial. If you go back and you look at surveys, you will see that doctors were already lowering the tidal volume, but that was still not proof. The two positive trials were landmark trials. These were extremely important. The Amato trial from Brazil and the ARDSNet, these were very important. So they gave us a lot of certainty. In the editorial, I pointed out that it's very important that because when you do the trials were set up as 6 versus 12 ml per kilogram. It was set up that way. But that's not a physiological measurement. That's a dosage, like a drug dosage. And I pointed out that the physiological signal was the plateau pressure, because this relates to lung injury. And I gave the example, this would be like taking somebody with a hypertensive emergency. And the only way you treat the hypertensive emergency is based on the beta blocker in milligrams per kilogram. And you never measure the blood pressure as you're treating the hypertensive emergency. Can you imagine any doctor who would recommend doing that? But that is precisely what has been done for the last 20 years with the ventilator.
Yeah.
I mean, they have finally come around in 2021. The same people who have written all these guidelines in 6 ml per kilogram, and they've said, we need to stop using ml per kilogram, and we need to look at the ventilator from a physiological perspective. I said all of that in the editorial in 2000, but I obviously was extraordinarily ineffective because I did not influence how people practiced. They've been giving 6 ml per kilogram. There is no data that tells you that 6 ml is superior to 11 ml, 10 ml.
Yeah.
No? And and the most recent guidelines are not 6 ml, they're 4 ml.
Even lower.
So I mean, if you breathe at 4 ml yourself, you will be extraordinarily dyspneic. This is just,
of course.
The people who are writing this, they must never have done it on themselves. I mean, for most of my research, I'm always the first experimental subject. That's just the way it is. You know?
You prove it in yourself.
Yeah, I've done all these type of things, and so, I mean, but I can issue, I breathed CO2 sky high. I've breathed oxygen that brings it down into the 70%. I've, all of these different things, PEEP, CPAP, whatever. But I mean, in terms of operating with a tidal volume of 4 ml, that's worse than all the other stuff.
Way below the physiologic. I mean,
Yeah.
physiologically, we breathe at 6, my Spanish, 6
Yeah.
ml per
We
kilo.
breathe. It's about. I mean, we breathe. An adult person, I can't tell you in babies, but in most adults, it's about 400 ml. Okay, 4 to 500 ml. Yeah.
Yeah, in babies, it's almost the same.
Okay.
The tidal volume, it's pretty much conserved. About mammals, I mean,
Yeah. Okay.
babies are mammals and are
Yeah,
humans,
yeah.
but they are like 5, 6, no more than 6 ml per kilo. So
Yeah.
why did
But I mean,
we?
but that is in a normal baby. As soon as you, so if you have somebody who has lung disease in the ICU,
Mhm.
and if they have infiltrates on their, that's because that's usually they will have an infiltrate. They'll have something on the X-ray. With that, you're going to have major stimulation of the sensory receptors. So you will no longer be breathing at 6 ml. Your normal reaction is to breathe at probably 8 ml.
Yeah.
You go higher.
8.
Okay. And so that's what you need for comfort. And so when the doctor comes in and, as I say, puts you on like Procrustes bed and starts cutting off your legs to try and make you fit in the bed.
in the bed.
Yes.
Yeah.
That is
But
torture.
well, that's wonderful because the discussion led us to another, in my view, epic conversation, academic discussions during the pandemic about the role of, I mean, some colleagues sent me questions to you about the PCLI, the self-inflicted lung injury, and many colleagues are saying, well, in this patient with lung injury, if they start breathing above 6, like we are saying, they can get injured by breathing. Do you think there is enough biological and clinical plausibility for it? Do you believe PCLI is a thing? Or the second question, does it change my clinical management?
Oh, yeah. I mean, well, they're two very different questions. Yeah. And I mean, and the answer is never straightforward and simple. So the bottom line is, I do not believe there is sufficient data to tell us that PCLI actually exists. I'll explain why. And then secondly, if it does exist, it has a major influence on your management. So, I mean, they're two totally different questions.
Okay.
So, I mean, the first thing is, and the worst part is, the conversation of PCLI largely has just arisen in the last 3 or 4 years. And it's right in the middle of a pandemic. And it markedly influences the approach to using endotracheal intubation. And one of the main things we have learned in the COVID pandemic, that mortality is very much related to the use of endotracheal tubes. That once you intubate, because once you intubate somebody, the entire equation changes. So if you believe in PCLI, the treatment for PCLI is intubation and placement on mechanical ventilation. Mm-hmm. So it's an extraordinarily important question. The main reason it's an extremely important question is because the treatment is extraordinarily radical. I'm practicing, tomorrow in the ICU. The most radical thing I can do in the ICU is intubate somebody. This is radical.
Yeah, it changes the equation.
The whole equation totally changes. Okay. And the skill required to intubate somebody is minuscule. It requires very little skill to use a kaleidoscope and move that tube into the trachea. It's that much skill, okay, compared with lots of other stuff. The skill required to watch a patient and say that this patient doesn't need intubation. That is a far greater skill. Yeah. Okay, so it takes you a few months of training to know how to stick in a tube. It takes you about 10 years of experience to know when you can easily get by without sticking in a tube. And for the patient, You're going to make life and death decisions for the patient.
So it's much more difficult to decide not to intubate.
That's the consequence of once you have PCLE, because I've engaged in conferences with panels and whatever else, and they tell me, and this was the best insight, and this was from Athens, Greece. They told me, oh, Dr. Tobin, we make the diagnosis of PCLE after we intubate. So we first intubate, and then we justify the intubation by saying the reason we stuck in the tube is because they had PCLE. So
okay, no, that's not the way, the right order.
I believe they were extremely honest, and I suspect that they were extremely insightful. But it's not the way the world is supposed to work.
But the rationale about thinking PCLE in the non-intubated person with lung injury, you have this, pneumonia.
The rationale is straightforward. It is based on the studies that have been done in animals. It's basically all the studies of Dreyfus and all these old studies that were the basis behind the low tidal volume. And so if you use very high tidal volumes, you cause volutrauma, you cause alveolar injury. And so, but these were with extraordinarily high tidal volumes. I remember visiting, Dreyfus's lab, and he put the rats on the ventilator, and within 5 minutes, they're pouring out pulmonary edema. But they're sky-high pressures. I mean, you're talking about plateau pressures of 40, 50. Okay, so you're causing that. So the fear is that if you have somebody who is in a lot of distress and they're taking large tidal volumes, then
large meaning above 12.
Well, this is a different story. All of these questions have different answers, okay?
Yeah.
So one of the biggest problems is, how do you measure tidal volume in a spontaneously breathing patient? I can assure you that it's not possible to do.
Stop right there. Why not? We have ventilators.
You don't have the methodology. I mean, I've been measuring tidal volume and writing about tidal volume since 1983. I've the largest, I'd suspect by far the largest number of measurements of tidal volume, because I use the Respitrace. The problem of using spirometer and pneumatachographs to measure tidal volume is you get into the Heisenberg principle out of quantum physics, where you change the very variables by your method of measurement. So it's very complex. So
you simply don't know. If you use it in
I can measure the tidal volume using a Respitrace in a healthy person, a person with disease, but not in a critically ill patient who is not intubated. Okay. They're very different. I've made all those measurements in intubated people. I made all these measurements in weaning, in people on the ventilator, but these are already with tubes in place.
That's if they don't have, how do you manage?
Once you have an endotracheal tube in place, you can attach a pneumotachograph. If you have a spontaneously breathing person, you cannot do that. There will be a pneumotachograph built into your non-invasive machine, used for non-invasive ventilation. But that pneumotachograph is operating at a very poor level of accuracy.
Certainty and accuracy, okay.
Because you need very careful calibration of the flow rates. These will give you numbers, but these numbers have nothing to do with reality. But there are lots of numbers. There's tons of numbers.
But how do you
numbers you want, and you can publish all these numbers, but they are not reality. Well,
but how do you manage those patients?
So if you have a patient who you're looking at, and you believe that the patient is in significant distress, and that this patient is likely to get into trouble without receiving mechanical ventilation, I use mechanical ventilation. But it's not going to be based on whether he has PCLE or is at risk of PCLE. I don't need that concept. It doesn't help me. I mean, if I see and I palpate the patient's sternomastoid, I'm going to be assessing the patient's work of breathing, based on clinical science. So that's going to be far more important to me. I will evaluate, look at the patient, and I say, if we don't intubate this patient is likely to crash and have a cardiac arrest in the next half hour. Yeah. So I mean, you don't delay in a situation like that. You immediately intubate the patient and put him on the ventilator. If I feel that the patient can do okay with non-invasive ventilation without intubating him, then I will say, let's try non-invasive. Let's give a trial and see if it begins to work. But these are going to be pragmatic decisions made on an individual patient, that based on your assessment of the underlying clinical features of the patient. And to me, it's my physical exam that's going to be far more helpful. I sure as hell don't want inaccurate measurements of tidal volume. I don't need somebody
but you know, Professor, you know that many people from all around the world will say, well, we experts have to give clinicians some kind of guidelines, some kind of numbers to follow, to measure, to monitor. So I see, and I agree with you that the subjective assessment of this patient is the most important thing. And just be at the bedside, trying to detect clinical deterioration. But where are the numbers? You're saying an intensivist that, wait a minute, see your patient. I mean, you are introducing a whole bunch of variables which are subjective. I mean, I'm playing devil. I
follow all that. So the question I would ask back, because you're a pediatric intensivist. So when your 8-year-old daughter comes into the ICU, do you want her to be managed by somebody who all they're doing is looking at some kind of guidelines? Is that the level you want to operate? Or do you want somebody who will stand at the bedside and try and figure out as best as possible what is going on in this little girl?
Yes, of course.
It's perfectly fine.
It's clear. The answer is clear.
All these guidelines are
cookbooks.
They're fine for other people, but not for my daughter. No, I don't think so. Yeah.
So, of course, Professor Tobin, many people have asked to me, please ask Tobin, how does he manage these patients when it is tubed? I mean, for example, a colleague from Colombia called me and say, please ask him, what would you not do in a mechanical ventilation patient with RDS? What you don't do?
Yeah. So you have to be very careful. What I'm talking to you earlier is about whether you intubate somebody. Once somebody is on the ventilator, it's very different. Because it depends on the accuracy of your measurements. So for example, if you have somebody on the ventilator and you're looking at taking them off the ventilator, I believe numbers are extremely important, because I published on the frequency to tidal volume ratio. Right. So, I mean, obviously, this is right. So, I mean, this is purely a number, but this is a number that's measured, provided it's measured accurately. Then, you know, and you're looking in a specific situation. You cannot switch from that to saying about PCILI. That's the trouble. Likewise, if you have somebody before you're taking them off the ventilator, I believe if somebody is on the ventilator, one of the most, and particularly in the context of ARDS, one of the most important numbers is the plateau pressure. So and you need to make sure that you're looking at a proper plateau, that you're not just looking at the number that's spit out by the ventilator. You need to look at the tracing and make sure that it really is flat when you do an inspiratory hold, that you're really getting an accurate physiological measurement.
In static conditions.
What? under static conditions.
Okay.
And it needs to be on the assist control mode at the time that you need to know what you're doing. And
Yeah.
so you get it. It's very simple to do. It only takes, less than 1 minute to do it correctly. Okay, provided you do it correctly. But that is extraordinarily valuable information to get the plateau pressure. And so if I'm looking at somebody on the ventilator and I see that the plateau pressure, most people on the ventilator are going to have plateau pressures of around 22 or lower.
Mhm.
Okay, that's the usual. So in somebody who is a tidal volume of a plateau pressure of 22, for somebody to be saying that they're wanting to lower the tidal volume, these people are into torture.
Asphyxiating
would
their
be
patients.
experts at doing waterboarding. They should sign up for doing waterboarding. Okay, that's what you're dealing with.
Yeah.
On the other hand, if you're seeing that the plateau pressure is up at over, let's say 28, 29, that's very
Close
worrisome.
to 30.
And once it's up there, then you need to get your tidal volume down. You need to try and do everything you can to get the tidal volume down if that's where you're at. Okay. So I mean,
you feel comfortable going between 6 and 10, for example.
Sorry, I'm sorry.
You might feel comfortable with that if the plateau pressure is low and not reaching 30 or so, managing those patients between 6 and 10, and you are, if the patient is fine.
I never look at the ml per kilogram.
Repeat
That has nothing to do with reality. That was a construct to do the randomized controlled trials. It was perfectly valid way of doing it, and I congratulate him for using it. It was a very key way, but it's not the signal. It's not the physiological signal. The only physiological signal is the plateau pressure.
And what about the driving pressure? It's the same.
It's the same.
It's the same.
I mean, this is pure math. It's just doing subtraction. That's fine. I have no problem. If you prefer doing it in driving pressure versus plateau pressure, that's perfectly fine. These are individual stylistic choices.
So, what? Now I know that you don't measure how much ml per kilos that's the patient, but what you won't do in a patient with RDS.
Yeah, I mean, the key thing is I will not let the tidal volume keep going up once the plateau pressure is up around. I won't allow it unnecessarily. So, I mean, I certainly get worried if I see the plateau pressure at 28. If I see the plateau pressure at 22, I certainly do not care what tidal volume the patient is getting. It just doesn't make any sense. I want to know what is the plateau pressure. And then it is, so I mean, what I'll do is I will maneuver the settings on the ventilator and I look at the waveform. I mean, I customize it for each individual patient to try and get the patient as comfortable as possible on the ventilator to improve the patient-ventilator interactions.
So this led us to another question from another colleague from Chile, who said, please ask Tobin, what alternative besides ECMO would you first offer to those kind of patients with RDS in the edge of protection? You know, they have the plateau pressure around 30, 32. You try to lower your tidal volume a bit and the plateau pressure doesn't go down. What would you offer to those patients? What do you think about alternatives once you reach that point besides ECMO?
Yeah, but this is not confined to mechanical ventilation. This is a general principle in medicine. Okay, and so if I take somebody with acute severe asthma, which will be a common problem I deal with, I'll often have those patients on a ventilator with very severe asthma. And they are extremely tight for 10 days on the ventilator. There's no break in their asthma. And for years I've been hearing, well, we need to try magnesium, we need to try anesthetics, we need to try all kinds of other things. I've been hearing that since the early 80s, okay? I say, no, what we need to do is we need to continue beta agonists, and we just continue them every day, and we wait. We need to be patient. And we are waiting on the response of the patient. And often after 15 days, they will break. The asthma will break, and suddenly you come in the next morning and the asthma has gone. The night before is exactly the same for 15 days.
A sudden improvement. Yeah.
And this is how the body works. I've seen this so many times from the early 80s on, okay? But many of these patients will be dead if we had to try all the fancy gadgets that people have been telling me we need to use, okay? So I despite all that I've written about the dangers of evidence-based medicine, I'm a firm believer in science. There's a difference between science and EBM. But so I want to know that the therapies have been actually proven to work. I stick with therapies that are proven to work. I'm very cautious about using the latest fashion that people believe. There's a paper somewhere, or there's something on Twitter that said that this particular approach is good. I can assure you I will not be using that.
I use Twitter.
No, I'm saying the therapy that's recommended. If the only support you're able to tell me is that somebody said something good about a therapy on Twitter, yeah, that's fine. Okay.
No, okay. But in a way, you can expand about evidence-based medicine and how it changed our approach, if you are agree with them, because evidence-based medicine, you have this paradigm about RCTs, and we need RCTs to test our interventions. So you need, in a way, what do you mean about the dangers of evidence-based medicine?
The way you stated that is extraordinarily naive.
Yes,
okay.
I am.
Yeah, that's fine. So the thing is, that is assuming that before 1982, that nobody knew how to practice medicine. The first paper on evidence-based medicine came out in 1982. This is to say that William Osler was an idiot. I don't think so. I would imagine that William Osler was a far better doctor than 99% of doctors that are working today. Okay, so it just doesn't make any sense. This is triumphalism of a pure arrogance. Okay, it just doesn't make sense. So the randomized controlled trials began in 1952. Okay, with the isoniazid trial for tuberculosis. So they didn't begin in 1982. They've been around for 30 years before EBM was ever announced. And so these people are puffing up their own ego.
Yeah. And we intensively have a big ego, right?
Yeah, that's fine. I mean, but again, the focus always has to be back to taking care of the patient.
Professor, another one. And this might be troublesome for many, but the question is simple: how do you set PEEP in these patients, in these RDS patients?
So, I mean, there's all kinds of approaches that can be used to setting PEEP. And in my youth, I mainly set it based on the PO2 and would, have measurements of oxygenation. And to a certain extent, I still do that. And then I use esophageal balloons at a stage, because we've inserted esophageal balloons in hundreds of patients for research, for other, but it's primarily in terms of work of breathing. So we have no trouble. But esophageal balloons, just for clinical decision making, a lot of the time, you probably can make the decisions without doing that. It varies. And so the main purpose I would see of PEEP in the setting of ARDS, which is distinct from other settings, but in the specific setting of ARDS, I want to get the pressure volume curve in the lower range above the lower inflection point. And in most patients with ARDS, the lower inflection point is going to be somewhere maybe around somewhere between 7 and 12. Typically.
Not more than that.
So, yeah, so that's where you're going to have it. And so generally, if
1-2 points above that point.
And so if I set the PEEP at around 12, I believe that without dropping an esophageal balloon, that is going to be above the lower inflection point. But I will also, as I titrate the PEEP, I will want to measure the plateau pressure, the blood pressure, and the oxygen saturation at the same time. And I make sure that the resident writes these all down on a piece of paper.
Okay.
Doesn't tell me that he keeps them in his head. I don't like the resident's head. I like them on paper.
And how do you manage, to how extent do you permit hypercapnia? I mean,
for hypercapnia?
Yeah.
I use permissive hypercapnia. So I mean, it is.
How much? Give me some numbers written in the paper.
I mean, whatever it is. I mean, I don't aim for any CO2. What I'm looking at is lowering the plateau pressure. That is the driving signal, is to get the plateau pressure down. Then the PCO2 goes up, and I don't care how high it goes up. I mean, a PCO2 of 100 doesn't bother me. Because
but the patient won't be
if it's going up slow, if it's going up slowly, the patient will adapt to that. It depends. It will also depend on the pH. If the pH is above 7, and the patient is slowly adapting. I mean, if the pH, particularly if the pH drops and the blood pressure drops, well, then it's a totally different situation. So you have to take into account the different variables.
So if your patient is around 12 of PEEP, approaching or near 30 points of plateau pressure, then you try, after you try to lower your arterial volume a bit, he or she persists severely hypoxemic. What would you do?
I wait. I mean, the thing is that someone else.
How long? Please.
Someone else will come in at nighttime. I'm not in the ICU 24 hours around the clock.
Yeah.
So every evening the gremlins invade the ICU, and when the gremlins come in, they do other stuff. Okay, that is the reality, and so they will have inflicted all kinds of other ideas. That's the reality.
And you go back the next morning.
Well, if the gremlins will probably
have gone.
If the patient has been moved on ECMO during the nighttime, I can't remove the ECMO the following morning.
But how much of an hypoxemia patient or hypoxemia level would you tolerate? I know, and you have written a lot about the PF ratios.
Well,
that you don't believe on those,
right? But it's PO2 is one of the single best measurements in medicine. It's an exquisitely precise measurement, provided that you don't divide the value by the FiO2. But PO2 in and of itself is a beautiful measurement. So I mean, if you have somebody because we know this from the COVID with the happy hypoxia. I mean, I have a paper on the happy hypoxia.
Yeah, of course. I was later trying to
that's fine. So I mean,
something about it.
So I mean, patients will do fine at quite low levels of PO2. So I mean, you have to make the decisions, as to where. Certainly, if the PO2 is 60, there's nothing. You're perfectly fine at that. I mean, but many of the patients with the happy hypoxia, they will have PO2s down at 50, even down to 45. So by and large, I mean, where you get, but you never want to be at the level, you never want to be on death's door. It's not as if you can treat these. If you see somebody with a PO2 of 50 and you're easily able to somehow make maneuvers that bring up the PO2, you need to do it. But you have to know what's going to be the consequences of the maneuvers.
Costs.
And you have to so you
harms.
have to, it's a
Yeah.
trade-off between the problems of the signal and versus the solution.
Totally. Professor, I mean, during the pandemic, there have been a lot of discussions about how, first, it was like COVID patients have a different kind of RDS. You think so? And
No.
the second one is, what do you think about the change of practice or the move towards more invasive ventilation, more paralysis during the first stage of the pandemic in 2020?
Oh, yeah. I mean, this was extremely real.
Yeah.
I mean, so in the first patient in our ICU that was intubated, I remember asking within hours of intubation, please send me the blood gases immediately before intubation and immediately after. And I got sent the x-rays.
Not the blood
I said,
gases.
but x-rays are not blood gases.
Those were the gremlins.
They showed me the x-rays were full of infiltrates.
Okay.
I said, but I've never intubated a patient based on an x-ray. How could you be doing that? And then I looked at the PO2 and the PO2s were 90.
The PO2 before the intubation?
Yes.
Oh.
And then, because then when I wrote my paper in the Blue Journal on basing the management on physiology, and in that paper I said, if you want to increase mortality in COVID, the best way to increase mortality is to intubate people. Liberal use of intubation, okay? And I remember that, that was, somebody told me they sent it to the head of their local ICU in various places. And they said they thought that the purpose of intubation was to protect the nurses from being spat at by the patient.
That happened. Yeah,
Yeah.
a lot. Big time.
And I can tell you, in one of the leading ICUs, pediatric ICUs in North America, this was happening 18 months after the beginning of the pandemic. I remember an attending contacting me because there was a 12-year-old girl admitted and everybody wanted her intubated. And the reason they wanted her intubated is that they might all get COVID if the issue wasn't intubated. That's 18 months into the pandemic.
Why happened that to us? In your experience, why did you foresee?
No.
When the pandemic started, that we could be able to change to that level our practices?
Yeah, I did. I mean, it was because I had the privilege of being part of an email string. There was an email string of the leading mechanical ventilator researchers around the world. They were all communicating, and I was stunned by what I was reading. Okay. And there were people from certain countries who said, we know far more about this than you know yet, because we've been seeing this for the last several weeks. And the main message is, as soon as you see them, you need to intubate them, because you're going to intubate them sooner or later. Okay. Once I read that, I said, that is extraordinarily insightful, because that is precisely what you don't want to do. But I mean, that people were signing their name to these statements.
Yeah.
Okay. And these are all household names. Okay.
It's
you
hard to
recognize-
read today. If you read those guidelines today, you feel
No, they're
ashamed.
not guidelines.
Yeah.
This is emails.
Oh, yeah. But many of those
Mu- mu-
emails
mu-
turn
enormous-
into
much
written
more-
papers,
What?
top journals. Many of the content, I assume,
Oh, yeah.
of those men are published in peer-reviewed journal, high
yeah.
impact, and
Yeah.
those were the recommendations early in the days of the pandemic.
There were the recommendations of WHO,
Yeah.
the World Health Organization. Okay.
Yeah.
They very clearly said, you can go back and you want the date. It's the 28th of January, 2020. Okay, you can find it
Yeah.
right there. And they say you need to intubate all these people. And you know what the recommendations are based on?
More patients.
Middle East Respiratory Syndrome,
Yeah.
MERS, okay, which is happens, the world literature in the ICU on MERS are 12 patients.
Yeah. Few.
And these were intubated because there were cleared failures of non-invasive ventilation, and they didn't give one data point, not one, in the Annals of Internal Medicine. The paper is in the Annals of Internal Medicine. You go and look at it, there's not one data point.
Yeah. It's sad. It's sad in a way. But Tobin, what have you learned? What have you learned along the pandemic? It is a broad question.
It's a human behavior is what I've learned. I mean, it is that people will follow a crowd. People want to be fashionable. They want to follow what other people are doing. And the most difficult thing is to try and think from first principles. People don't want to do that. They absolutely do not want to do that. And I mean, because you're too young. I mean, I operated during the AIDS epidemic in the early 1980s.
And the flu pandemic as well.
Yeah, it was an epidemic as well. But I mean, at that time, the doctors and nurses did not react. All of them, we were all frightened of AIDS. We were afraid of picking it up. But in the early days when it wasn't understood, but we recognized that you took care of patients. When somebody came into the ICU, the reaction is not, how do I protect myself? Unfortunately,
the patient should be the center.
COVID, the COVID was very different. Okay.
Professor, it's been an honor. I really enjoyed this conversation. I hope many people can watch it and learn from you. And please read your pieces. It's been one of the jewels of the pandemic. Have been reading all the articles you have written along the pandemic about please reason, take care of the patient. Do not try. That was what I learned from you, is try to avoid the pandemic of bias. This bandwagon effect and physiology should lead us, particularly in an ICU. Thank you, Professor. It's been wonderful.
Thank you for inviting me. Thank you.
Bye-bye.
Bye-bye.